Hello, I am Dr. Keith Burke, a professor of behavioral sciences in the San Diego City College Alcohol and Other Drug Studies program. The AODS program at San Diego City College is a state-funded vocational training program to prepare students to become certified alcohol and drug counselors. The AODS program provides all the necessary coursework to sit for the state certification exam, as well as the ability to get an associate's degree in alcohol and other drug studies. The credits that are gained at San Diego City College are transferable for those people who are pursuing further education at four-year universities. So today's training video, I am going to talk about trauma-informed care in substance use treatment facilities.
Alcohol and drug counselors work in a field in which many of our patients and clients have been traumatized. Some people watching this video have likely experienced trauma themselves. And so using good trauma-informed care principles, I want to let everyone know that in the course of this presentation, I am going to be discussing trauma in some detail and its impact, with the goal ultimately to help to generate safety and empowerment and healing for those who have been traumatized and find themselves in a substance use treatment care setting. So let's talk first about trauma and its impact. So this definition of trauma from the United States Substance Abuse and Mental Health Services Administration, or SAMHSA, says that trauma results from an event, a series of events, or a set of circumstances that is experienced by the individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. So trauma is, in a clinical definition, not just the actual trauma experience, but it also includes the lasting adverse effects of that experience on an individual's functioning. So trauma may be a single event, like a car accident or an assault, or it can be repeated or numerous events, meaning multiple series of traumas. Certainly veterans coming back from war zones have numerous repeated trauma experiences all in a period of time, or sustained chronic experiences. A domestic violence or an intimate partner violence situation would be a good example of sustained chronic trauma, or some children growing up in households in which there is abuse may have sustained chronic trauma experiences over a better portion of their entire childhood. So trauma can be experienced directly or through exposure of an observed event. So watching someone go through a trauma experience, watching someone be assaulted, watching someone die can actually have an impact on the individual who's observing it, and they experience it as trauma. They experience that mentally as trauma, they experience that psychologically as trauma, and they experience that physiologically as trauma. You all have probably had that experience where you've been watching a show on TV or something where somebody gets hurt unexpectedly, or they fall down or something, where your own nervous system gets a jolt just by watching it, and maybe your own heartbeat starts to beat a little faster, or you have like an intake of breath just watching the experience. So that's what's happening physiologically, where we can experience trauma through an observation. The essential idea is that anything can be traumatic if it overwhelms the individual and if it's experienced as threatening or harmful. And this is a very important point. It is not the job of the alcohol and drug counselor to establish a threshold for what constitutes trauma or not. If the individual experiences it as trauma and it's threatening and harmful to them, then we accept it for what it is. For example, if somebody has experienced a traumatic event in the form of being what they would call beaten, from their parents. And if somebody asks, well, what do you mean you were beaten? Well, I mean, I was spanked a lot, and my mom used to use a spatula, in doing that, and she'd smack me not only on my butt, but she'd smack me in the face with it. And an individual says, oh gosh, that's not trauma. I went through that too. Right? That would be not a trauma-informed care response, and it is not our job to decide what's traumatic and what's not. Because trauma's impact is extremely individualized, meaning it is very hard to predict how one person will respond to a traumatic event when compared to another person. There is an enormous amount of research about this, particularly with veterans in war zones who you may have 4 people in a Humvee together who experience an explosive device, and how all four of them survive, and how all 4 of them react, and the lasting impact of that may be radically different. So we can't predict which trauma is going to be impactful, which is not, and how someone's going to experience that. So certainly the type of trauma and the context in which it occurred will have a lot to do with how it's experienced. The length of the trauma exposure, was this a brief exposure to trauma, or was it a chronic sustained exposure over a long period of time? Previous trauma experiences. So there's a lot of research indicating that people who have had previous trauma experiences are more vulnerable to lasting impact from subsequent trauma experiences. Losses associated with the trauma. In California, during the last couple of summers here, there have been catastrophic fires that people have been through, where they've been required to evacuate towns and leave, where they may have lost their homes, they may have lost animals and pets in their home, and others who don't understand or are not practicing a trauma-informed care approach may feel like, oh, well, but you're still alive, you remade it, you made it, the insurance company, can cover the cost of the home, but the losses associated with that trauma have long-lasting impact. If there are available resources available, that has a lot to do with how trauma is ultimately experienced over time. Typically, in catastrophic events that involve large numbers of people, there will be various medical teams, psychological responses, earthquakes, things like that. The mobilization of resources quickly to get out and interact with the people that experience the trauma is really important, because when having resources nearby and having an intervention quickly, there's some evidence that helps to mediate or lessen the ultimate impact of the trauma. Individual attributes and personality factors seem to have something to do with how people experience trauma and its impact as well. Certain types of personalities may experience trauma in a less impactful way. Other types of personality factors, emotional sensitivities, things like that, may suggest that the individual experiences trauma in a more serious and long-lasting way. And then there's a cultural meaning behind how people interpret traumatic events. In some cultures, there may be a conceptual narrative understanding of what's happening that helps to mitigate long-term trauma experiences, where as in other cultures, there isn't that kind of an understanding. It does not. So we do know that repeated chronic or multiple traumas are more likely to produce pronounced symptoms and responses, meaning if the traumas happen again and again, then you tend to see a longer and more intense impact. So as we talk about trauma-informed care principles, we're going to refer to people who have gotten through trauma as a trauma survivor. So a trauma survivor is anyone who has experienced trauma in the past or had a traumatic stress reaction, and they are still here, they're still alive. Now, this is a change from victim. So using the term survivor, a trauma survivor, instead of a trauma victim, is to avoid re-traumatization. Being seen as a survivor is a more empowering position to be in than to be seen as a victim. And so it's important for alcohol and drug counselors who are working with patients or clients who've been traumatized to refer to them as a survivor of that experience rather than being a victim of the experience. So we know that trauma survivors not only experience the trauma itself and the immediate acute impact of that. Obviously, if you are in the midst of a forest fire and you're attempting to evacuate and you can see the fire as you're driving away, that's going to have an immediate impact, an acute immediate impact, right? Beating heart, increased pulse, a fear response. But trauma often changes the individual in very significant ways, where they continue to have a trauma response even though the trauma is no longer a threat. So the person who goes through a catastrophic forest fire and is being evacuated may be in a position in which there's no fire, there's no immediate threat, but yet their nervous system is reacting as if the threat may be imminent. And that's the essence of why we are talking about this lecture today, is because many of the trauma survivors having these long-ranging impacts end up in substance use treatment facilities. So there's many ways that people can be changed by a trauma experience. So changes in the nervous system itself. So the nervous system, the sympathetic nervous system, kind of the speeding up and responsiveness to stimulus in the environment, the parasympathetic nervous system, which is the part of the nervous system that slows us down and shuts us down, gets us into a relaxed state, ready to sleep. There's a natural kind of move throughout the day in the parasympathetic and sympathetic nervous systems. And after people have been traumatized, often the regulatory function of the nervous system has been altered in some way, where they're stuck in a sympathetic, high anxiety or anger state, or they're stuck in a low, frozen, depressed state, which leads then to emotional regulation challenges. So the person has a hard time regulating their emotional system. We've all had experiences before where we've gotten angry or anxious, due to some stimulus in the environment. Somebody cuts us off in traffic, right? And we have this momentary, oh my gosh, and I could have crashed, and gosh, what a jerk. But normally what would happen is we have a spike in our nervous system. And then as the person drives away, we get out of our car, we get to work, whatever it is, the anger and the anxiety goes down a little bit. It might spike a little more when we tell our coworkers about what just happened, but for the most part, the nervous system will regulate itself. But people who have been traumatized and survived that often then don't have the same regulatory ability. They may get cut off in traffic and remain in this heightened state of anxiety and anger and fear for a long period of time after the potential trauma has passed. Trauma survivors often develop avoidance behaviors where they are not only avoiding things associated with the trauma or the traumas themselves, but it starts to really expand out into a generalized state of avoidance. A good example would be, let's say that I'm in my office at the college and I open up the door to my office and there's a tiger in the hallway. So I have no idea how that tiger got there, but I have a sudden spike in my nervous system, right, of fear and anxiety. And I'm like, oh my God. And I slam the door shut and I'm traumatized, right, from this event. And so, I make some phone calls. Somebody comes by. The tiger is caught and saved and taken away, and there's no more tigers in the building. But the problem is, when I go into my office and my door is closed, when I go to open the door, my nervous system starts responding as if there could be a tiger in the hallway that's going to catch me by surprise, the same way that it happened previously. And so I start having a nervous system response. And then the mind starts to work on it. Well, there was a tiger in the hallway and I'm on the 5th floor of this building. Maybe there's other tigers in this building. And so I start avoiding my office, and maybe I start avoiding the building altogether. And then the mind starts thinking, well, if there's tigers in one building at San Diego City College, then maybe there's tigers in other buildings in San Diego City College. And so now I start avoiding going to the college altogether. And then my mind may start thinking, well, if there's tigers that could be in buildings at San Diego City College, it could be tigers in buildings in San Diego. And so I start avoiding San Diego itself. And then my mind may think, well, if there's tigers in buildings in San Diego, there could be tigers in any building, anywhere. And now I start avoiding going into buildings. And so it can really start to compound itself to where these avoidance behaviors really make it difficult for the person to do anything. Similar to avoidance behaviors is states of hypervigilance or being on super high alert. So using the same tiger analogy that I was just giving, maybe I'm not avoiding my office, the building, the campus, the city, buildings altogether, but maybe every time I'm in a building, a city, on the campus, in my office, I'm in a state of hypervigilance and high awareness, feeling that this could happen again, and living kind of in a state of high anxiety. And so for trauma survivors, these nervous system changes like this are often a significant impact from the trauma that ends up impacting their day-to-day living much longer after the trauma has passed. The idea here is that the trauma has become wired into the brain. Now, wired into the brain, it's a neurology or a neurological reference of how the brain works. And without going too deep into it in this introductory lecture on trauma-informed care, it is true that the brain literally changes when people go through a trauma experience, and literally physically changes, like the actual neurons in the brain and how they wire and respond to other neurons in the brain change. And so what happens for trauma survivors is that their changed brain often then equates to them feeling hypersensitized and vulnerable to any trauma signals in the environment. So a trauma signal, for example, using my tiger analogy, could be anything suggesting a possible tiger. Or for somebody who has survived a forest fire, in California, a trauma signal could be the smell of smoke in the air, which might just be from the neighbor, having a fire in their fireplace, but then it creates this trauma response because it's a signal of fire, which was previously a trauma experience. So there's many common responses to trauma. So intense emotions and emotional dysregulation, as was just talked about. Emotional extremes, so being in a really high excitable state, but it also includes being in a numbed state where you can't feel anything. Cognitive impairments, meaning it's difficult to think clearly. Excessive states of guilt, especially if there's loss associated with the trauma, feelings of what could I have done, or feelings of guilt that the trauma survivor somehow feels like they must have brought that upon themselves in some way. Altered perceptions of self and others, meaning you don't see yourself or other people in the same way after this. Dissociation is a type of psychological and mental disconnection from the experience. The body may be in the room, but the mind's not there anymore. Hypervigilance and hyperarousal, as I mentioned previously, being in a state of high alert, having anxiety and depression. Sleep disturbances, again related to the sympathetic and parasympathetic nervous system being altered. Individuals may have a hard time getting into that deep, relaxed state, especially if the trauma occurred during a relaxed or sleep state. People who have experienced trauma while sleeping often have an extraordinarily challenging time going back to sleep. Just to stay in the same examples that I've been using to avoid labeling lots and lots of different trauma experiences. If a person was asleep and then suddenly the calls for an evacuation for a forest fire came, then obviously going to sleep may be very difficult because the nervous system remains in a state of alert, of, oh my gosh, something could happen while I'm sleeping. Flashbacks and intrusive memories of the event is a very common response to trauma. And then physical symptoms or somatization, which is essentially experiencing the trauma as a type of body pain or other physical dysfunctions. A person may develop the sensation that they're having a heart attack and they go to the emergency room and there's no evidence the person's having a heart attack, and it's more of a panic attack or an anxiety response, or sometimes people may even develop bodily pains that medical professionals can't find any reason for those body pains, and it's a response to the trauma experience. Traumatic stress reactions then often evolve into functional impairments over a long period of time, meaning that the kind of heightened responses and changes that happened after the trauma experience start impairing a person's ability to just live life, do things like take care of activities of daily living, like taking showers and brushing your teeth and paying the bills and things like that. It can start to impact relationships, social relationships, interpersonal relationships. It can start to impact an ability to work and be in a work setting. And then the dysregulated mood symptoms, which I've talked a lot about here in the last couple of minutes, about the nervous system being too high, too low, states of anxiety, states of depression, et cetera. These are normal responses to abnormal stress, but these functional impairments and dysregulated mood symptoms may last for a really long time. This is a great quote by Viktor Frankl, who was a psychologist in a concentration camp during World War II and studied trauma experiences and responses. In his career, he said that an abnormal reaction to an abnormal situation is normal behavior. So what we as clinicians are looking for is when we see these long-term impacts, normal responses to abnormal stress, but they're enduring long after the event, then this may suggest a red flag and require some kind of targeted treatment. So some of these red flag responses to trauma is seeing in our patients or clients any lingering functional impairments, as I mentioned, in daily living, social, relational, occupational, self-destructive or self-harming behaviors. Again, how people respond to trauma is incredibly individualized, but there are a number of people who have experienced trauma who engage in things like cutting, using sharp objects to make cuts into their own body, eating disorders, other types of high-risk activities, individuals coming back from war zones and buying motorcycles and doing wheelies 100 miles an hour going down the interstate freeway. Right, these would be examples of high-risk, potentially self-harming behaviors. And then reenactments. So a reenactment is really complicated. A reenactment is essentially the person ending up back in an experience that either invites or causes a re-traumatization. An example of this would be a person who survives a domestic violence or an intimate partner violence situation. They're in a relationship in which there's violence and abuse. They get out of that relationship, and then they end up right back in another relationship with another person who's also abusive. The general public often sees reenactments as bizarre, and they can't understand why would you put yourself in a situation like that. Again, you know how much this caused problems before, but there's actually some evidence that a reenactment may be a type of subconscious attempt to recreate or relive the trauma, or some kind of fragment of that experience in an attempt to master it or get through that. Reenactments actually happen in trauma therapy. So there are a number of trauma therapies, EMDR, prolonged exposure, cognitive restructuring. These are very specialized psychological interventions that are done with people who have experienced trauma and are having lasting impacts, in which the therapist very carefully re-exposes the person to some aspects of the trauma and in a very controlled way, helps the person master their own nervous system response, develop a coherent narrative understanding of what happened to them, to where it's not having this long-lasting impact well after the trauma has been experienced. So a person engaging in a reenactment or putting themselves right back into a situation that invites being re-traumatized, there's some theory that this may be a subconscious attempt to essentially do what they would otherwise do with a trauma-trained therapist. The problem is, trauma therapy is very complicated. It really takes a lot of training. It is very, very dangerous in some ways because of the vulnerability to being re-traumatized, which would then compound the problem, because the more times a person's experienced trauma, usually the longer and more intense the lasting impact. But when people reenact a trauma experience, they may actually subconsciously be attempting to get through that experience in a different way. This is a very cursory, short introduction, really just touching on the surface of the many different ways that people can be impacted by trauma experiences. But the important thing to note is that trauma survivors are at extremely elevated risk for developing mental health symptoms and disorders, certainly PTSD, but other types of mental health disorders as well. They're at an elevated risk for impairment in many areas of their life. They are at an elevated risk for developing physical health problems, including sleep disorders. And there's lots and lots and lots of evidence that trauma survivors often end up with substance use disorders. The use of the substances in many ways being a response to the nervous system impact and the emotional dysregulation that happened from the trauma. So working in substance use treatment, we see lots of trauma survivors, people who have experienced trauma. So from that has been developed some principles of how to be trauma informed when providing care. Now, this is not just unique to substance use treatment. Trauma-informed care is really employed in any kind of medical or behavioral health facility. But the basic principle of trauma-informed care is the same for everyone, which is avoid re-traumatization in treatment. We're trying to deliver services in a way that doesn't traumatize a person again. So an individual can be re-traumatized in a couple of different ways. So one is being exposed to multiple traumatic events. So, if somebody experiences a trauma, the example I gave before, they're in a domestic violence or intimate partner violence situation, they get out of that situation and then they end up back in another DV or IPV situation, then that could be seen as re-traumatization. They're being traumatized again in a second event. But the other way that trauma survivors can experience being re-traumatized is to re-experience traumatic stress, because the current situation mirrors or replicates in some way the prior traumatic experience. And so what that means is that the individual may have gone through a traumatic experience. They may have been in a domestic violence, intimate partner violence situation and setting, and they get out of that, survive that, and then their boss is upset because they, forgot to file paperwork on a certain time, and the boss kind of barks at him and yells at him like, God, like, what's the matter with you? Didn't you know that this was due? And suddenly they are re-traumatized. They're re-traumatizing the same kind of stress that they had when they were in the DV relationship. Heart rate starts racing, right? Elevated pulse, a state of fear. And the person may end up quitting that job, right? Having a really powerful response to what happened because they feel re-traumatized. So when somebody is re-traumatized, it usually means that something in the current situation is mirroring or replicating the previous trauma. This could be a sensation of some sort, your senses, a bodily sensation is a reminder, the way that you're interacting with others, the example I just gave you of the boss yelling, responding, to one's surroundings. The tiger that was in my hallway and, going to the zoo would be potentially a very re-traumatizing experience. because while I'm in the zoo, even though I decide not to go to the tiger exhibit, I hear a lion's roar or something like that, right? And so I'm suddenly transported back to the experience. Someone can be re-traumatized in responses to an interpersonal interaction. People who have been sexually molested or sexually assaulted previously, finding it extraordinarily difficult to engage in any kind of a sexual way, even with someone that they love and feel safe with later on, because that replicates in some way the previous experience, and feeling emotionally or physically trapped. There's interesting research into trauma about how, especially people that experience chronic and traumatic stress, a big reason why the impact may be so intense and long lasting was the feeling of not being able to get out of that situation, both emotionally and physically. And so any sensation of being emotionally or physically trapped, right? I don't know how to get out of this room could end up triggering the same kind of response. The main reason why this is very important is because clinicians who are trying to be helpful, clinicians such as alcohol and drug counselors, may sometimes inadvertently re-traumatize a client by replicating the events or the dynamics of the original trauma and trigger overwhelming feelings and reactions associated with the trauma in the very client that they're trying to help. So if using the same example I did with a boss, we could do the same thing, with an alcohol and drug counselor. Individual is a trauma survivor from a domestic violence situation, and now they're in treatment, and the client was supposed to do an assignment, based on one of their treatment goals, and they don't finish it. And the alcohol and drug counselor, in a kind of an annoyed way, like, all right, well, you said you were going to do it. What happened? Right. So the clinician, presumably in that example, is not attempting to traumatize their client, but they may inadvertently re-traumatize their client because the way that they're speaking to them replicates the original trauma that the person went through. So there's many example triggers that could potentially re-traumatize in a clinical setting. So the treatment setting environment itself may have some memory or some kind of an association with the previous trauma, the clinician's attitude or the type of intervention they do, or the emotional state of the clinician themselves, other clients' behaviors and relational dynamics. Maybe something in their interactions with another client, could create kind of a memory. Maybe the client is a reminder of the person that they run a domestic violence relationship with, and so they suddenly have a trauma trigger because of that. Clinicians being overly authoritative when interacting with clients. In residential settings in particular, this often happens where the clients are living in the same place in which they're experiencing treatment. People don't always behave appropriately when they're in substance use treatment. And so being overly authoritative, really rigid with the rules, barking at clients, knock it off, if you don't do this, then you're going to be required to clean the bathroom, right? Things like that could really be a trauma trigger. Using a confrontational approach in any aspect of treatment, you just need to admit you're an addict. Until you admit you're an addict, then you're never going to heal. That wouldn't be recommended in any setting, but certainly when potentially working with trauma survivors, that kind of confrontation is not a good approach. Using seclusion, restraint, or timeout practices that isolate individuals, as a punishment, and individuals put into isolation, or they have to sit in the corner or something like that. That can be a big trauma trigger. Again, it's a feeling of entrapment, both emotionally and physically. Focusing on the trauma experience as a mental health disorder instead of on the person who experienced the traumatic stress. So, like, for example, if the trauma survivor has been given a diagnosis of PTSD, and they're having a trauma response while in treatment, and the clinician's like, oh, well, that's your PTSD that's right now, right? And that's why that's happening. That is depersonalizing in many ways and can actually be re-traumatizing itself, rather than really focusing on the person and whatever they're going through who experienced the stress. Giving treatment assignments or practicing treatment interventions that humiliate the client or are designed to make the client feel stupid, whether consciously or not. Having the client write 50 times on the whiteboard, I will remember to make my bed in the morning, right, or something like that. That could potentially re-traumatize. Challenging or discounting reports of abuse or other traumatic events. I gave the example earlier of a person who was traumatized and reports that as being beaten by their parent. And then somebody starts to ask, well, what do you mean by being beaten? And, when told like, being hit with a spatula, like, oh, that's nothing, my parents did this to me or something like that. Whether it's the counselor or other clients challenging or discounting the abuse can be experienced as a traumatic stressor. And allowing abusive behavior of one client towards another without intervention. So when counselors allow one client to speak in a contemptuous way or bully another client or something like that, and they don't do anything about it, even if it's just witnessing two clients where one's being abusive towards another could be re-traumatizing for the person observing it, clearly would be re-traumatizing if they're the one that is experiencing abusive behavior from another client. Another way that clients could be re-traumatized in a clinical setting is to have their feelings or behaviors being seen as pathological or negative or a problem. Look, Maria, this kind of like crying in group, I mean, this is not okay. This is your PTSD and I get it, but I mean, this is a real problem. Like we need to work on this. That's not going to be experienced as a supportive intervention and may make the person feel re-traumatized. Another way to potentially re-traumatize clients in a behavioral health setting like substance use treatment is being unaware of or failing to ask about the client's traumatic history and how it significantly affected his or her life. We're going to talk a bit more about that in this presentation, but it's many times difficult to talk about for the people that have experienced and survived trauma. And the clinician has an ethical responsibility and a clinical responsibility to be aware that clients may come into our settings with trauma experiences. And we need to be able to ask about those experiences in a way that it gives the person permission to talk about it and to start to process and understand what happened to them. All right, the principles of trauma-informed care. So this lecture is primarily for alcohol and drug counselors. Certainly there may be mental health clinicians also who are listening to this lecture. But it's important to understand that alcohol and drug counselors are going to be interacting with and treating people who are survivors of trauma. They will be interacting with and treating clients who have post-traumatic stress disorder or PTSD. Even in a substance use treatment facility, there may be a licensed mental health clinician employed by that facility, and that clinician may also meet with the client and provide trauma therapy, but the clients are still going to be in group settings. The clients are still going to receive individual recovery counseling sessions. The clients are still going to be in a residential setting. And so the alcohol and drug counselor is going to be interacting with, and in many cases, treating someone who's a trauma survivor. An alcohol and drug counselor certainly can help a trauma survivor practice deep breathing when they're getting into a state of heightened anxiety, while they're in session. They don't have to run down the hallway and say, oh my God, I need to get the mental health clinician. And so this is talked about at great length in the co-occurring disorders course at San Diego City College. But it's important that alcohol and drug counselors just understand that we treat people with co-occurring disorders. That's part of what our job is alcohol and drug counselors. So the principles of trauma-informed care are applied in any kind of behavioral health setting by all those who are interacting with trauma survivors, including alcohol and drug counselors. So we'll review some of the principles of trauma-informed care in these next slides. So the principle of trauma-informed care is to deliver behavioral health services with an understanding of trauma and its impact, and view the trauma through a clinical and cultural lens, meaning that we recognize how we interact with clients and the therapeutic experience itself is going to help impact how individuals perceive and process traumatic events, whether positively or negatively. So what that means is we need to be aware of the fact that how we deliver care, how we talk about trauma with our clients, how we respond to that trauma is going to really have long-reaching impact when the person leaves our treatment facility or while they're in treatment, in terms of whether they see this trauma as an empowering experience or a negative experience. So trauma-informed care requires vigilance by the alcohol and drug counselor to anticipate and avoid practices that are likely to re-traumatize people. Now, sometimes this includes agency policies. So if the alcohol and drug counselor is working at an agency which by policy has some kind of a punishment, people need to be put in isolation in a room, for 3 hours and not allowed to talk to somebody, in response to failure to do a chore or something like that. Agency policies can also be re-traumatizing, and alcohol and drug counselors have an ethical responsibility when they recognize that a policy may be re-traumatizing trauma survivors to do something about that and to address it directly. So trauma-informed care also upholds the importance of client autonomy, choice, and willing participation in the development and delivery of treatment goals, clinical services, and counselor interventions. What that means is that clients have to have the right to choose to do what we're asking them to do, or to choose to participate in any kind of a setting. We cannot force anyone to participate if they're not comfortable to do that. And clients ultimately have the choice of whether or not this is something that they want to do. Now, obviously, to some degree, saying I'm not going to any groups, because that's going to traumatize me, probably isn't going to work in most substance use treatment facilities, but hopefully there's going to be a trauma-informed care discussion with that person about what's so triggering for them. But let's say, for example, a client in an individual counseling setting or even a group counseling setting suddenly has a very strong emotional response. They start crying in a very strong way, moving towards sobbing. And the counselor says, "What is it? What is it? What's happening right now?" And maybe the client shakes their head and they hold up their hand. Well, that's a signal to the counselor of no, right? I'm not at a point that I'm ready or willing to talk about this. So the counselor's like, "What? You need to talk about it. Come on, like bring it forward. If this isn't something you talk about, then it's gonna live inside you, and you're gonna keep having these strong feelings." That would not be practicing trauma-informed care. It is not respecting the client's autonomy, their choice, and their willingness to participate in that moment with the intervention that the counselor is trying to do. So the idea in trauma-informed care is to be mindful of what the client is willing to do, what the client is able to do at any point in any kind of a service that could potentially be traumatizing or re-traumatize. And again, as I said, examining any intervention or agency procedures that might be in place on a policy level as well. Okay, so some of the trauma-informed care counseling principles specifically, these are SAMHSA recommended informed counseling principles. SAMHSA, as the United States Substance Abuse and Mental Health Services Administration, sets general treatment policies and guidelines for how services should be delivered in the country. And in many cases, then states adopt those policies and principles, which is certainly the case in California. California, really across the board as a whole, has simply adopted the SAMHSA policies and principles regarding care when it comes to serving substance use disorders, specifically for sure. So the first principle is to conduct trauma screenings and assessments. So any substance use treatment facility should be conducting trauma screenings and assessments. So a trauma screening can include intake interview questions. So when a client first comes in and you do an extensive intake, the questions need to ask about trauma. Have you previously experienced any kind of trauma? Have you experienced trauma therapy before? Sometimes there may be formal self-report questionnaires, like a type of mental health screening questionnaire that's done independently of an intake. That would qualify too. But the idea is that any substance use treatment facility needs to, when a person comes in, ask questions in a formal way to try and identify if someone's had trauma experiences. Now, somebody may be a trauma survivor and they come into a new treatment facility and they're not ready to talk about that. So just because we asked about that at intake doesn't necessarily mean that we're done asking those kinds of questions. So we need to maintain informal observations that could indicate trauma experiences and then respond accordingly. So this is the difference between a formal screening and an informal screening. So an informal observation may be simply something as simple as noticing somebody's having a reaction to something someone else says. Perhaps in group, somebody is talking about a traumatic experience that they went through, and you suddenly notice that another person in the group is looking away, or they start bouncing their leg, they're looking anxious, or maybe they start to cry. And so in this case, even though they may have said on their intake, no, they haven't experienced any kind of trauma experiences, it would be important to use that observation to screen and assess whether the person actually has experienced and survived trauma. Using empathetic inquiry about trauma experiences, that means the way that we ask about it needs to be done in a very empathetic and compassionate manner. Going through an intake questionnaire. Okay, my next question, have you ever experienced trauma in any way before? Right, that's not empathetic inquiry. And if the person has, that could actually be experienced as a type of re-trauma. So being empathetic and compassionate about the way that we ask about it. And the recognition too in doing trauma screenings and assessments that an individual may need to consider a lot higher level of care. So if they come into an outpatient substance use treatment facility, and in the screening for trauma experiences, they clearly have survived trauma and they're still having acute reactions to that trauma, the outpatient substance use disorder treatment facility might not be the best place for them. And so this part of the federal no wrong door policy, this is the expectation and requirement that the agency, the counselors themselves recognize it is what it is and see if they can connect that person with services more suited to treating the trauma. The second in trauma-informed care principle is to use a solution or strength-based perspective, meaning that we, instead of focusing on the problem, we try to focus on the strengths. It's very similar to solution-focused counseling techniques, which we talk a lot about at San Diego City College. But the idea is to identify that the person has survived trauma and to try and figure out what strengths they do have in place, what coping skills they already know about, what resources they are able to access, and we incorporate that into the treatment planning to address the trauma. Now, this lecture is mostly focused on trauma and trauma-informed care, but this is true about co-occurring mental health symptoms and disorders in general. In a substance use treatment setting, it is critical that treatment goals include addressing mental health symptoms or disorders as part of the substance use treatment in an integrated manner. Now, another aspect of using solution and strength-based focus is to focus less on the personal history and details about whatever the trauma is and more on the adaptive solutions. So if a client tells us that they survived a domestic violence situation, we don't need to ask them about that. Well, what do you mean? And what happened? And then what? And then what? That actually is potentially re-traumatizing. So much like the solution-focused counseling techniques, we need to understand the gist of what happened enough so that we can be helpful. But in using a solution strength-based perspective then is, okay, let's stop talking about the past and let's move now into what can we do about this to be helpful now and in the future. The third principle is to reframe client challenges as opportunities for a different experience. So many times trauma survivors have excessive feelings of guilt. We talked about how they may see themselves in a victimized kind of way or personally responsible for what had happened to them. And so a good clinician using trauma-informed care counseling principles is going to take the trauma response that the person's having and help them see this as this is a normal reaction to what happened to you. And let's use this and see if we can talk about a way to have a different experience. And then developing trauma-resistant self-care skills. So coping strategies, emotional regulation skills, support networks, etc. The third trauma-informed care counseling principle is to promote trauma awareness and understanding. So recognizing the prevalence of trauma and its possible presence in your client's presentation. SAMHSA says this about a number of co-occurring conditions, but the general comment about co-occurring disorders in general is that they should be an expectation in a substance use treatment setting, not an exception. That's an important distinction, because if you are expecting to see something, then you're looking for it. If I tell you to expect somebody to, knock on your door in the next hour because they're going to give you a prize, well, then you're probably going to be really paying close attention to the door, right? And seeing if somebody is going to show up in the next hour. Whereas if it's an exception, right? If I tell you like, well, somebody in the city of San Diego is going to have somebody knock on their door and they're going to deliver a prize, then you're probably not paying too much close attention to your door. So promoting trauma awareness and understanding is recognizing that any client that comes through the doors may be a trauma survivor, and watching how the client acts and interacts in a treatment setting, and noting that any type of presentation could potentially be related to trauma. Tailoring our counseling style and intervention to be responsive to trauma survivor needs, including expressions of empathy and hope. This is important, going back to one of the previous slides about how confrontational techniques and ways of talking to clients could potentially re-traumatize. If we're not aware that the client is a trauma survivor, and we use interventions, that are confrontational, we could potentially cause a lot of problems. Whereas if we're approaching each client, recognizing they could be a trauma survivor and tailoring the counseling style to be responsive to that, even before they've identified it, then what we're doing is showing good trauma awareness. And then providing trauma education to all clients about trauma and its effects. This is a very strong recommendation, and in San Diego, where I live, virtually all of the treatment facilities, the substance use treatment facilities, have some kind of trauma psychoeducation group, or a trauma process group, or a trauma support group, based on this SAMHSA recommendation. People who are trauma survivors, often don't understand what happened to them, and learning to understand about the long-term effects, how the nervous system is impacted, the ability to be able to talk to other clients that have gone through trauma experiences and get the social and emotional support from that is all really critical for treatment for people that are trauma survivors. Now, it is important to note that trauma education may generate a trauma response. And so it's very important that clinicians that are providing trauma education are also in kind of a heightened alert to see how the person's responding to this, and do this in an empathetic way where we can check in with what's happening for you right now. Again, recognizing autonomy and willingness to participate is ultimately the client's call, not ours. Continuing on the trauma awareness, remaining open to discussing trauma while avoiding questions about details or requiring highly detailed descriptions from the client about the nature and consequences of their trauma. That's really critical. Asking people highly detailed, questions. A client who was sexually molested, asking a detailed question might be like, well, where was this? What room was this in the house? How long did it happen? Where exactly were you touched? Things like that, not helpful and potentially re-traumatizing. Again, using a solution-focused approach, we need to know enough to understand the gist of it, and then in an empathetic way, help move into what can we do to help you with this. Now, note that the client may decide that they need to talk about this or want to talk about this. In that case, we don't want to shut it down, but it needs to be client-driven, not counselor-driven. So in other words, if a client starts talking about, I'll use the example that I just used of sexual abuse, a sexual molestation experience. The client's never talked about it with anybody, and they suddenly start talking about it with the counselor, and they are going into some detail about where it happened and what room it was in and where exactly they were touched. That's appropriate for the client. And in that case, we are going to be accommodating and simply listen without asking more detailed questions or inquiries on our part. But again, it needs to be client-driven, not counselor-driven. The danger is if a client starts talking in detail about their traumatic experiences and we shut that down. No, it's okay. I don't need to know, right? Like, well, yeah, I get it. Let's talk about the solutions. Again, that could be experienced as a type of re-traumatization. So we're going to remain open to discussing it while avoiding questions coming from us, the clinician, that requires them to speak in detail. Being respectful, open, accepting, non-judgmental, and empathetic when the client describes trauma experiences. The clients who come out of intimate partner violence relationships, often they may both be a survivor and they were the perpetrator, at the time. Many times, two individuals in a domestic violence relationship may both be abusing each other at different points. And so, if a client's talking about that and they're describing, what they did as a perpetrator, again, in a very non-judgmental, accepting, clinical way, communicating that we understand, what happened. And most of the time, it is understandable. Yeah, I can see why that happened. It sounds like it was a reasonable strategy at the time. Not that we are condoning it, right? But we're remaining open and accepting of what the client's sharing. And then bringing trauma awareness to the rest of the clinical team and the residential staff members. Many times this will happen at multidisciplinary team meetings, where maybe a client opens up to a counselor or they talk in group, about a trauma experience that the other clinicians and other staff members may not be aware of. So communicating that, amongst the staff so that they're also careful not to re-traumatize the client. If we notice, other clinicians or staff members acting in a way that potentially re-traumatizes, or again, if there's policies in place that could potentially re-traumatize, bringing that trauma awareness to the rest of the team. Creating a safe environment. So creating a safe environment, part of that is from the beginning, clarifying for the client what's going to be expected of them in treatment. Trauma survivors generally don't do very well with surprises because many times the trauma itself was a surprise that they weren't anticipating. And the surprise dimension of that has a lot to do with the long-term impact or the intensity of how trauma is experienced. So very important to clarify exactly what's expected of them. You're going to be moving into our residential treatment program. There will be another roommate you'll be sharing a room with. Here's what your requirements are. You'll need to meet with your counselor, tomorrow. We'll help get you there. I mean, really laying all this out so that they're not caught by surprise. If they didn't know they were going to have a roommate and they walk into a room and there's another person there, that could potentially re-traumatize. Approaching trauma issues and concerns in an empathetic, matter-of-fact manner. I had an old supervisor when I was in training, say to me, it's the bedside doctor manner. So what that means is when somebody is talking about trauma, we are not going to go, oh my God, I can't believe you experienced that, right? I mean, that intense kind of response like that could potentially be re-traumatizing. Nor are we going to be dismissive. Yeah, no, I understand. Lots of people have that, right? Like that's not a matter-of-fact, empathetic manner either. It's being able to talk about it in a way like, oh, gosh, I'm so sorry you went through that. It must have been a really challenging, difficult time for you. It's matter of fact, it's open, it's understanding, while being delivered in more of a balanced way. That tends to create more safety. Adjusting presentation style, body position, tone, volume of speech to suit the client's level of engagement. I personally got some feedback on this when I was a younger in-training clinician. I was working with mental health patients for the first time, and I have kind of a loud projecting voice. It helps me a lot when I'm in a lecture hall, not so much while I'm in a one-on-one counseling setting. And I was in an internship setting where our sessions were recorded, and a supervisor had said to me, Keith, you need to adjust your style. You're a bit too loud and excitable and intense. And look, your client, can you see how they're sitting in their seat? I think you're potentially generating a trauma response. And so it's important for us just to note how we look, what are we saying, how are we responding to something to make sure that we're doing it in a way that doesn't traumatize our clients. Continuing on, anticipating and adapting to any physical, psychological, and emotional triggers from a client that could suggest trauma experiences. Maybe the alcohol and drug counselor is running a process group, and again, using the example earlier, somebody is talking about their own experience, and the counselor notices that somebody on the side is having a response, they're showing anxiety, or they're starting to cry in a way that could suggest a trauma experience trigger. and maybe the counselor, had an exercise that they really were planning on doing, a worksheet or something like that. There's only 15 minutes left in the group, and the counselor really wants to do that worksheet. Well, trauma-informed care counseling principles would say, abandon that worksheet. You need to adjust and adapt. And you've got a client who may be having a trauma trigger response. We need to go to that client and do what we can to talk and process that. Responding with empathy and care when the client is feeling emotionally flooded. That seems like that would go without saying, but sometimes somebody might be having a really powerful emotional response and they're sobbing. And if the counselor is like, okay, it's okay, stop, right? It's okay, just stop, right? That doesn't necessarily come off as empathy and care. And so being able to respond in a way that the client feels that their emotional floodedness is contained and that we're going to help them with it, which we'll talk a bit more about here shortly. Discussing and implementing strategies to cope with unavoidable triggers and reactions. This is part of mental health relapse prevention planning. When we know somebody is a trauma survivor and we know that they get trauma triggered, talking with them, what are the triggers that might be out there? What are the warning signs? What are we going to do when those things show up? And respecting the client's personal space. So many people who have experienced various types of assaults and abuse are very, very sensitive to people getting too close in their physical space, very sensitive sometimes to being touched. No alcohol and drug counselor or really any clinician should be touching clients without their permission. Definitely not people who are trauma survivors. Overall, being respectful of their personal space. And then providing consistency in the client interactions in the treatment processes. So that's really important also. There's many different types of traumas, but definitely the people who have experienced trauma, interpersonal traumas, domestic violence, interpersonal violence, long-term chronic child abuse. Many times part of the trauma is that in the cycle of violence, the trauma, the abuse kind of happens, and then there's this honeymoon period where, the abuser's acting like everything's okay, and then there's a buildup, and then there's the abuse again. And so it can be really traumatic in seeing from the clinician that they're being inconsistent. They're saying one thing and they're doing something else, or they respond in an empathetic way, and then later they're responding in more of a harsh way. So it's really important to provide consistency in the client's interactions, providing honest and compassionate communication, when circumstances come up, and follow through with what was agreed upon. If the counselor says they're going to talk to someone, then they need to talk to that person. Being an empathetic client advocate when needed. So, if a client is opened up to the counselor about something and they're expecting that the counselor is a support for them, and then they feel abandoned, because the counselor didn't help them, didn't say anything to somebody else, didn't advocate for them when needed, and providing feedback. A point of note about consistency, sometimes as behavioral health clinicians in substance use treatment settings, we have to follow rules, right? We are required not to be necessarily a police person, but we need to administer or support rules and regulations, in the treatment setting. So like if the, client leaves group early, so maybe there's a rule in place in the treatment setting that if a client leaves group early, then they won't count for attendance, and they're going to have to make up that group later. Well, if the client, gets emotionally flooded and leaves group, and then the counselor, says to him, "Oh, it's okay, I understand. This was a trauma response." That's actually not consistent with what they were told from the beginning and what you're doing to other clients, and that could actually potentially be problematic. It's also really important, again, with the no surprises, that clients understand like what's required and what the counselors have to do and what they're required to do. And so, in that case, letting the client know, hey, you remember when we talked about before how it's a rule that if you leave group early, then it doesn't count and you'll have to tack that group on. At the end of your outpatient stay, and the client says, you don't understand, I thought you understood me and I was feeling really triggered. No, I totally understand. And it's okay that you did that. But we also talked about how this is the agency policy, right? And so this is what we're going to have to do. I totally get it. I understand. Let's talk about it. Maybe we can talk about some ways to stay in group, or, or step out and come back in, when necessary. So again, you're providing consistency. Okay, the fifth principle is to make it a point to practice grounding techniques with clients. Clients with past traumas and who are trauma survivors often have a window of tolerance for stressful experiences. The window of tolerance is a reference to the nervous system, what people are able to tolerate in terms of intensity and length of time. But it's important we note that many times people who are trauma survivors have a lower threshold for stress, and when they exceed that, then they may dissociate, they may get flooded with anxiety. An example I just gave about somebody leaving group because they're flooded. It's important to note that this is normal. This is a normal response to a trauma experience, and so grounding techniques is a go-to frontline primary intervention to use with trauma survivors, and alcohol and drug counselors can do this and will do this just as much, if not more so, than mental health clinicians. So practicing grounding strategies, these are simple tools that can help bring trauma clients back into their bodies, help them calm down so that they can start to feel safe again. So how you can use grounding techniques, there's many of them out there. These are not all of the techniques, but it's important to stop whatever you're doing. So whether this is an individual session or this is a group setting, or this is just, the client in a residential setting or in a hallway, if they're having some kind of a flooded trauma response, it's important we stop whatever we're doing. So if we were talking about a particular something in an individual session, we need to stop talking about that. Whatever it is, the client's lost the ability to respond at that point. So before we practice grounding techniques, we want to check in with the client, what's going on right now. I'm noticing it looks like you sort of emotionally have left the room. Are you feeling kind of spacey, or maybe disconnected to what's going on? Hey, you're looking really emotionally flooded right now. I'm watching you. It looks like your anxiety is really just increasing. We need to essentially share our observations so that the client feels seen and understood and heard before we try any kind of an intervention. It's common often to teach clients words like I'm feeling triggered right now, or I'm dissociating right now, to help identify this kind of a state. And then we want to remind the client, like, okay, no problem. Like I'm here with you. I'm in the room with you, and I'm not going to let anything bad happen to you. So many times this kind of trauma response may also have intrusive memories coming back of whatever the trauma setting is. They may be dissociating or not really mentally in the room with us, but they may have also mentally gone to another place. And so just to prep them for grounding, reminding them that they're here in the room, it's okay, I'm not going to let anything bad happen to you. Sometimes considering a timeout and switching to engage them in conversation about a less emotional topic will work. That was kind of like, usually this is going to be a less intense response, but something like, okay, why don't we put that in the parking lot for right now? We can come back to that. So maybe we can go back earlier on. You were mentioning having trouble with, your step one assignment that one of the counselors asked you to do for group. Do you want to talk about that? And maybe we can come back to this topic in a little bit. That's kind of like a real simple grounding technique to see if the client can bring themselves back to a state of baseline. But these are some other really common techniques, grounding techniques that you can use with clients that are feeling flooded or dissociating. You can ask them to feel their feet on the ground or parts of their body that touch the chair or the couch. So what that may look like is, okay, hey, so I'm here with you. It looks like you're maybe kind of dissociating and checked out. So I understand, and I'm here with you. I'm not going to let anything bad happen to you, okay? But I'm wondering if we can help get you back here in the room. So I'm wondering if right now maybe you can draw your attention to your feet. I want you to feel your feet and maybe feel the sensation of your feet pressing on your shoes, like the bottoms of your feet, feeling the shoes pressing against the bottom of your feet. Maybe feeling how your feet are pressing against the ground and they're solid. Your feet in the ground. And then maybe you can move your awareness and maybe notice your back. And just let your awareness go to your back and just notice the sensation of your back pushing against your chair. and how your back is touching the chair. There's a solidness there. And so you get the idea, right? So what you can do is draw attention to the various body parts and attempt to ground them, bring them back to baseline, back in the room by doing that. Asking the client to look closely and describe 3 objects in the room. So, again, using it appears you're having a response. Maybe you're not here. I'm here with you, et cetera, et cetera. And like, okay, like let's try and bring you back here. Right? It's okay. I'm here with you, and I'm not going anywhere. I'm wondering if I can get you to just look around the room right now and describe to me something that you see. Like, just pick something in the room and tell me what it is. Okay, I see the clock. Great. So tell me about the clock. What color is the clock? It's I don't know, brown. Okay, great. And what shape is the clock? It's in a circle. Okay, good. And when you look at the face of the clock, what does it look like? Well, it's got numbers. What numbers are you seeing? Well, I'm seeing the 12 and the 1 and the 2. You notice anything else about the numbers? Well, like between the 1 and the 2, there's like 5 dots. Good. And so what you do is you kind of walk them through this process of getting into some deep description. Now, what's happening is you're moving their awareness off of their internal state, which is likely contributing to the dissociation or the floodedness, and you're trying to move it to an innocuous external stimulus. The clock isn't particularly threatening in this case, right? So just really focusing in on the clock may give the nervous system a chance to come back down. Deep breathing, there is a slew of research about the effectiveness of deep breathing for people who are PTSD or trauma survivors, PTSD diagnoses, anxiety disorders, panic disorders. There are many variations of this, but just using a technique of asking the client to breathe slowly and fully. There's different variations of this, box breaths and things like this, but you can try the 6 breaths a minute. That is having the client breathe in for 5 seconds and breathe out for 5 seconds. Typically what you would do is, well, you definitely want to ask them first before you do this, but then you count with them. Like, okay, so what we're going to do is we're going to breathe in slowly and fully. We're going to breathe 6 times in a minute. Okay, so what I want you to do is breathe in, and I'm going to count to 5. Okay, you ready? Okay, breathe in. 1, 2, 3, 4, 5. Okay, breathe out. 1, 2, 3, 4, 5. And so that would be an example of a deep breathing technique. All right, we're going to take a little sidebar here. For those of you who are watching this video as part of a course at San Diego City College that you're receiving credit for, this is the keyword or key phrase non sequitur. So those of you who are taking a course at City College, which requires you to watch this video, you are going to be tested upon the conclusion of this video. And one of the questions is going to ask for the keyword or the key phrase. Now, this keyword or phrase is not going to be on the PowerPoint slides. The student is only going to know this keyword or phrase if they actually watched the video. So the key phrase for this video is turtles move slowly and deliberately. Again, the key phrase is turtles move slowly and deliberately. All right, let's get back to our scheduled programming. The 6th of the trauma-informed care counseling principles is to support client choice, control, and autonomy in a treatment program. So using motivational interviewing and a motivational interviewing perspective, we're not going to talk a lot about motivational interviewing in this lecture, but it's talked a lot about in the San Diego City College Alcohol and Other Drug Studies program. There's certainly a lot of it out there. Pretty much anybody in behavioral health nowadays has been trained in MI. Avoid advice-giving directives and be collaborative. So telling people what they should do is generally just doesn't work, period. That's kind of one of the big tenets of motivational interviewing, but definitely for trauma survivors, telling them what they should do to get through this or get over this is not helpful. We want to be collaborative about it. We're trying to create opportunities for client empowerment and development of confidence. Some of this is kind of reframing these instances as opportunities. So going back to the last slide and the client, that may be dissociating, by helping them learn to ground in the session, by focusing on the clock, by practicing deep breathing, etc. What we're doing is providing them an opportunity to empower themselves and to develop a way of trying to control their own nervous system. Delivering the message that the clients have valuable personal expertise and knowledge about their own presenting problems. This is another motivational interviewing tenet, but helping them understand, hey, I'm sure there's some things you've done before that's worked for you. What do you generally do, when you've been dissociating? They may tell you if they're in substance use treatment, well, I would use substances, which would be understandable. But in this case, really trying to evoke from them other solutions and things that they've done before that they know that works. Utilizing peer support and mutual self-help groups, and identifying and encouraging participation in trauma-related support groups with peers who have also experienced trauma. Lots of evidence here that trauma survivors find it very helpful to be around other trauma survivors. It's not just being able to communicate with other people who understand, but often it's learning from other people about what works for them, feeling like there's a sense of community. This could include traditional grief and loss support groups for sure. I definitely also DBT, emotional regulation groups, trauma survivor groups, etc. And encouraging recovering trauma clients to consider leadership roles as a peer specialist or training certification as a peer support provider. There's many facilities, many behavioral health facilities that are employing peer support specialists. Typically, a peer support specialist doesn't have as much education and training as an alcohol and drug counselor does, or as a mental health clinician does. But they do get some training in how to be a supportive person who's been there and provide a type of peer support, which again closely related to these kind of mutual self-help peer support groups can be very helpful. Identifying recovery from trauma as a primary treatment goal. This is very important in a substance use treatment setting to include treatment goals related to managing trauma and trauma states when we have someone who's a trauma survivor. People who have survived trauma and have long-lasting impacts, such as PTSD, are very vulnerable to, pardon me, very vulnerable to substance use relapse. The body state that happens when people are trauma triggered will often lead to a feeling that I need to use substances. And so by having someone in substance use treatment have all these treatment goals related to treating the substance use disorder, and there's nothing there about treating the trauma, is not going to be very effective. So identifying recovery from trauma as a primary treatment goal in substance use treatment. So, that includes a lot of things, normalizing it, which we've talked about, providing psychoeducation about traumatic stress and trauma-related symptoms. This can be an individual treatment goal. This can be done in individual sessions. This can be done in trauma groups. Addressing the relationship of trauma to substance use and mental health symptoms, part of the psychoeducation, and helping trauma survivors understand how trauma relates to why they use substances. And considering trauma triggers and coping skills in any kind of substance abuse or mental health relapse prevention planning. Providing psychoeducation and support through the development of coping skills, self-management of symptoms, and establishing a support network. That pretty much is a relapse prevention plan for trauma. The integrated relapse prevention plan is talked about in the AODS program in our co-occurring class, where substance use counselors help clients develop a relapse prevention plan that includes not just how to prevent relapse to substances, but how to prevent relapse back into these various mental health conditions. And so for trauma survivors, it's a relapse prevention plan to deal with trauma triggers. And then very important, trauma survivors have a very complex, they have a very complex diagnosis. Sorry, momentarily spaced on the word I was trying to say there. They have condition. There we go. They have a very complex condition. Teaching them how to do grounding techniques, teaching them coping skills, all of that stuff is really super important. But again, this introductory lecture is not going to get into any kind of great detail about the neurological or brain changes that trauma experiences make, but it's legit. People's brains have been changed when they've experienced trauma. Particularly when it advances to a state of post-traumatic stress disorder. And so it's super important that people who are in substance use treatment with trauma experiences be referred to a clinically trained trauma-based psychotherapist and strongly consider psychiatric medications for trauma. These are some statistics from the National Center for PTSD. The ratio, 55 out of 100 people who receive psychotherapy for trauma have no PTSD symptoms after 3 months. People who receive medications, 48 out of 100 or 48% have no PTSD symptoms after 3 months. But people who receive no specialized trauma treatment, only 8 out of 100 have no PTSD symptoms after 3 months. So even receiving psychotherapy and medications, this is definitely not 100% effectiveness, but you can see how much more effective it is for somebody to have trauma psychotherapy or trauma-based medication regimens in the treatment of their PTSD. All right, to finish this lecture out, we'll have a brief discussion about secondary trauma. Secondary trauma is an occupational hazard for those of us who work with trauma survivors. So secondary trauma is a trauma-related stress reaction or symptoms resulting from exposure to another person's individual trauma experiences. Sometimes this is referred to as vicarious trauma versus having direct experience. This often occurs among substance use and mental health counselors and other behavioral health clinicians treating clients with trauma. Essentially, what happens here is sitting with people who have experienced trauma and empathizing with them and bonding with them and working with them can start to create a trauma response in our own nervous system, even if we didn't have anything to do with the trauma. This actually was first really widely identified in Vietnam with the media who went to Vietnam, and they weren't necessarily on the battlefields, but they were there in Vietnam, and they were, interviewing and filming and spending time with the soldiers. And just by being with the soldiers and hearing about their experiences, they started to have, like, for example, they maybe never had an anxiety disorder or a panic disorder, and suddenly they start developing anxiety and panic just from hearing about this. It has since been very well established. Hearing about trauma, learning about trauma, you do that for long enough and your body's own nervous system starts to respond as if it was traumatized. And so it is definitely something that happens to those of us working in substance use treatment. It is a normal response. This could include physical or psychological reactions, so developing anxiety, or panic yourself from working with trauma survivors, avoidance behaviors during client interactions or even during supervision. What that may mean is that you start hoping that your client doesn't show up. Your trauma survivor who has PTSD and a heroin use disorder, right? You're treating that client and you start hoping that client doesn't show up to your sessions. Or you have a feeling that if you keep talking about this particular topic, then, suddenly the person's going to start talking about their trauma and you don't want to do that. And so you change this subject. Or you have a meeting with a supervisor and you avoid bringing up this client, or any discussion about this because you don't want to talk about it. Numbness, limited emotional expression, diminished affect. This is closely related to burnout, but specifically to treating trauma survivors. Sometimes clinicians start to become numb. They have a hard time having empathy anymore. They don't really, feel the person's sharing a horrific experience and there's no emotional reaction whatsoever. Developing insomnia, or negative thinking or depressed mood. Developing detachment from family, friends, other people outside of treatment setting. I personally had this when I first started working. I was working at a homeless treatment program here, or a homeless transitional living in a mental health treatment program in San Diego, and I was spending a lot of time working with trauma survivors and trauma clients. And I was finding when I was leaving and going home, I wasn't speaking to my wife or my daughter. I stopped going to, any kind of social interactions with my friends, to the point that my wife kind of called it out. And so, like any good behavioral health counselor, I had my own counselor, and I took myself right back into therapy so that I could kind of talk about this because I was essentially experiencing secondary trauma. It is a very, very common phenomenon. So to decrease the risk of secondary trauma, as I just mentioned, personal psychotherapy is a frontline go-to. It's really important to have somebody that you can go process with. Peer supports, being able to discuss this with your peers who are also doing the same thing. Supervision and consultation, being able to talk about this with supervisors, even if it's not necessarily going to a personal psychotherapist, going to another professional, who may also treat trauma and trauma survivors, and consulting with them about your experience, and getting ongoing training in treating trauma and trauma survivors. And then maintaining life balance, basic things like good nutrition, good physical health, having a good social life, hobbies that have nothing to do with doing behavioral health work, and setting clear limits and boundaries with clients, keeping your work life separate from your personal life. There's lots of stuff out there about doing this, but not looking at your emails, right, except during work hours, not looking at your emails, especially if you're at a residential substance use treatment facility. This is 24 hours a day, 7 days a week, and if you're off on Fridays and Saturdays, and you're looking at emails on Fridays and Saturdays, and you're responding to emails, then you're not setting a clear boundary with working clients. All right, so that's a lot of information. This is more of an introductory lecture into trauma-informed care and trauma-informed care principles. But I know that a lot was shared here. So there is a lot more out there, but really important that we are practicing trauma-informed care when working with the clients we're working with and patients in substance use treatment. And if there are any questions, feel free to either comment on the video, or if you have my email and contact information, please reach out.